Hello, my name is Megan Rogers, and I'm an associate professor in the College of Nursing and Health Innovation at the University of Texas at Arlington. I have an MSN in Nursing Education and a PhD in Educational Leadership and Policy Studies. Since starting my nursing career in the pediatric ED, I've served in numerous teaching and administrative roles, both in practice and academic settings. My research interests include high-stakes testing, transition to practice, disparities in educational persistence and attainment, informatics competencies, and the use of predictive analytics to target interventions for at-risk students. Throughout this boot camp experience, you've no doubt learned some essential nuts and bolts about being an educator, like how and why we deliberately map and evaluate our curriculum, what our accrediting agencies have to say about competencies in both the clinical and classroom settings, and how to develop high-impact exam questions to assess learner knowledge. We understand the importance of using exams not only to evaluate individual student achievement, but also to improve teaching and learning effectiveness in our programs. In this session, we're going to switch gears and pause to reflect on some of our common testing practices as educators. We'll begin with a discussion about the legal and ethical imperative for fair testing, as well as the negative impacts of high-stakes testing. We'll review findings of my recent research study associated with predicting NCLEX failure, and most importantly, we'll analyze how our common testing practices perpetuate inequities and shut the door of opportunity on students who could be successful. This presentation is a call to action for nurse educators to question our commonly held beliefs and practices related to ranking, sorting, and labeling students. So let's begin with an overview of the legal and accreditory guidance related to testing in nursing education. The National League for Nursing and many state boards have released position statements against the use of high-stakes third-party predictor exams for progression policies and have offered guidance on how to prepare exams. Today we'll review two important sources of information that would likely be referenced if you were ever to find yourself in court defending your program's use of exams. The first is the National League for Nursing's Fair Testing Guidelines for Nursing Education, and the second is the Standards for Education and Psychological Testing. This is a joint effort between the National Council of Measurement and Education, the American Psychological Association, and the Educational Research Association, the American Educational Research Association. This is the gold standard of testing in higher ed and the only source cited in Supreme Court cases associated with testing and high-stakes testing in higher ed. The standards for educational and psychological testing have been in place for years, most recently updated in 2014 and are currently being updated. So keep an eye out for those new guidelines in the years to come. NLN's fair testing guidelines state that faculty are ethically obligated to ensure tests and associated decisions are valid, evidence-based, and fair to learners. Let's take a deeper look at their guidance now. As we said, faculty have an ethical obligation to ensure that tests and these decisions associated with them are based on valid evidence, consistent across programs, and fair to all test takers, regardless of age, gender, disability, race, ethnicity, national origin, religion, sexual orientation, linguistic background, testing style and ability, or any other personal characteristics. Faculty have the responsibility to assess students' abilities and to assure that they're competent to practice nursing, while also recognizing that our current approaches to learning assessment are both limited and imperfect. Multiple sources of evidence and approaches for assessment of knowledge and clinical abilities are particularly critical when high-stakes decisions, such as progression or graduation, are based on the assessment. This is important for programs who are using something like an end-of-program OSCE, and those programs who haven't done the work to validate that those exams are actually measuring what they believe they're measuring. Tests and other evaluative measures are used not only to evaluate students' achievement, but as importantly, to support student learning, to improve teaching, and to guide program improvements. Standardized tests must have comprehensive testing administration and evaluation information readily available to faculty before they administer, grade, distribute results, or write related policies for test results use. Faculty have the responsibility to review and incorporate these materials in their communications to students about standardized testing and its consequences in their course. And lastly, faculty in schools of nursing have an ethical obligation to protect every student's right to privacy by maintaining appropriate confidentiality related to the testing process and to test results. The National League for Nursing provides additional guidance for educators who are selecting appropriate assessments and deciding how the results of those assessments will be used. Standardized exams must show evidence of reliability, content, and predictive validity, and evidence of fairness and equity, as shown by test performance across test-taking subgroups based on culture, race, or gender. This measure is known as differential item functioning. Vendors should provide technical manuals that provide information on the test blueprint, test development procedures, psychometric testing analysis, as well as norming procedures. All exams provided to students should be reviewed regularly for accuracy and content relevancy. Test takers are notified early in the program about the nature of the exam as well as how scores are going to be used. Programs document that students have read, understood, and accepted the testing guidelines. The administration, scoring, and integrity procedures should also be clearly documented and acknowledged by students. Inter-rater reliability and psychometric validity is regularly assessed and documented throughout the program on all assessments used for students. Students are provided detailed norming information on standardized exams. Predictive validity is performed on a periodic basis. Very important, more than one mode of learning assessment is used to make high-stakes decisions. This is really crucial in programs who are still using benchmark exams like ATI and HESI to prevent students from progressing in the program. But it also impacts the common practice of using a minimum exam average score to determine if a student passes the course, even if their final course grade is passing. It's important to note that by doing this, educators are bypassing the routine measure of academic progression, which is an overall course grade, or the Carnegie unit, or the credit generating, credit producing course. So when a student makes an A in a course, but their exam average is still below 70, and they're held back from passing the course, we have a little bit of a problem here. Schools should really consider this practice in the context of fair testing. So by now, we've determined that fair testing in this context means that all test takers are given comparable opportunities to demonstrate what they know and what they are able to do in the learning area being tested. But what additional guidance is provided for educators in the standards for educational and psychological testing? Standard 4.1. The process by which items are screened and the data used for screening, such as item discrimination, or differential item functioning, or DIF, for major examinee groups, should also be documented. Standard 4.6. When appropriate to documenting the validity of test score interpretations for their intended uses, relevant experts external to the testing program should review the test specifications to evaluate their appropriateness for intended uses of test scores, as well as fairness for intended test takers. Standard 4.7. The procedures used to develop, review, try out items, and to select items from the item pool should be documented. Plans for improving individual items, as well as the overall validity and reliability of future exams, should be developed. Standard 5.1. Test users should be provided with clear explanations of the characteristics, meaning, and interpretation of derived scale scores, as well as the limitation in the use of those scores. Now let's pause the video to test your knowledge with this 7-question true-false quiz. All right, let's see how you did. First, fair testing only requires attention to academic performance and does not consider personal characteristics like language or disability. This is false. Remember, in order to ensure that testing is fair to all students, we need to ensure that groups of students perform the same as others. Second question, faculty must ensure consistency in how test and testing decisions are applied across the program. This is true. Remember, you want to make sure that faculty governance is involved in the creation of a faculty and student-facing testing policy. This is reviewed on an ongoing basis. This is important to show accreditors as well as governing bodies should you ever be questioned about the fairness of your assessments. Next, we have faculty should review and use standardized test manuals before using tests in their programs. This is true. Every exam vendor should provide this information, and faculty must have a clear picture of the intended usage and exam specifications before using a third-party exam. Number 4, Differential item functioning refers to the process of scoring exams using a curve. This is false. Remember that the DIF, or differential item functioning, refers to the analysis of performance on an exam between groups of students. So looking at how non-English language learners performed on a specific question or an exam in comparison to the overall group, maybe looking at students based on race and ethnicity and how they performed on an individual exam or an individual item to ensure that all students perform the same regardless of their previous characteristics or demographic characteristics that they have prior to taking the exam. So next we have programs must document that students have read, understand, and agreed to testing guidelines. This is true. You want to make sure that prior to test day, students have an opportunity to review the policy and to understand how test scores are going to be used. That's important. Number 6, using more than one mode of assessment is important for high stakes decisions like course progression or graduation. This is true, and perhaps the most important takeaway from today's presentation. It's very, very important that we're not using just a singular assessment or a singular mode of assessment for high stakes decisions. So a common practice is at the end of, prior to the starting of a capstone course, the end of a program, students will often do a skills check-off or an OSCE where they're demonstrating their level of preparation. An inability to do this could result in not progressing either through the course or through the program. This practice is high stakes and it's particularly important on these things like OSCEs or skills checkoffs when you're using these modes of assessment. If you have not performed inter-rater reliability and validity, which remember reliability shows how often a tool produces the same results between different faculty, so how accurate or valid a tool is between faculty, between measures, whereas validity is a measure of how accurate a tool is at measuring what we say we're measuring. So we need that data on any assessment that we're going to use in our program, and we must make sure that we're using multiple methods of assessment. So in addition to a skills checkoff, we want to make sure that we have maybe a knowledge check and that those assessment data points are all used together in making decisions. We want to avoid the use of a single data point or a single mode of assessment to determine if a student continues in a course or program. And then lastly, to address grade inflation from easy course assignments, programs should look at cumulative exam averages separate from the overall course letter grade when determining if a student should pass a course. The answer here is false. You want to make sure that you're sticking to the routine measure, the Carnegie measure, the course grade, and you're really not using just assessments or just exams outside of the normal course grading schema to determine if a student passes a course. Before we move on, let's take one moment just to pause and reflect. Are there any practices in your current role as an educator that you're questioning after learning this information about our legal and ethical obligations? What goals can you set right now to ensure the assessments that you administer in your course are fair and valid measures of student knowledge? So let's talk about the perils of predictor exams and apply what we've learned about our responsibility as educators to ensure we're using exams for their intended purpose. We've got a real problem with test use validity when the results really only tell us who's very likely to pass NCLEX. And really, any of us could spend a few days in a classroom with our students and get a really good idea of who our high performers are. But that's not really what we're trying to do here. We want to know who's at risk. Now, because our first-time licensure pass rates are the primary indicator of nursing program quality in this country, nursing programs very often base admission and progression decisions on third-party standardized exams and other known predictors of NCLEX success, such as GPA, Science GPA, ATI and HESI scores, healthcare experience, and previous degrees. The over-reliance on known predictors of success is problematic because these practices are often founded on the assumption that students who are not highly likely to pass NCLEX are at imminent risk for failure. When in reality, many of these students who we label as at risk based on this benchmark scoring criteria still have a good chance of passing NCLEX. And this practice really shuts the door of opportunity for specific groups of students who are desperately needed to make our profession more accurately mirror the patients that it serves. Now, Daryl Spurlock was one of the first nursing education researchers more than 15 years ago to question our practice of using high-stakes NCLEX predictor exams like HESI and ATI. He found that predictor exams do a great job of identifying high-performing students who are very likely to pass NCLEX, but they're actually much less precise in identifying those with a high likelihood of failure. In Dr. Spurlock's research, 96% of students in the highest scoring parameter category went on to pass NCLEX. However, 76% of students who were placed in the do not progress category based on their scoring parameters and benchmark criteria still went on to pass NCLEX. So once you dive into these numbers, you quickly realize these exams predict that approximately 35% of all students will fail NCLEX. Now, I'm not sure about you, but I wouldn't accept a 65% pass rate in my program. So it's clear from the start that these exams over-predict failure, meaning they overgeneralize who's at risk. This may be okay when you're deciding who needs to study more, but very problematic when you're making the decision to kick someone out of your program. Now, when I first came upon this research, the program I worked in had set a benchmark HESI score of 800 as a requirement for graduation. Now, in a retrospective evaluation of the predictive validity of these exams in my own program, or in other words, how well these tests actually did in telling us how our students would perform on NCLEX, I found that only 18% of our NCLEX failures were actually affected by our current progression policy at the time. And of those students we held back from graduating, 49% still went on to fail NCLEX. We can really do better than a coin's toss chance of the intended outcome of any intervention that we employ in a nursing program. Now, if you're one of the 40 to 60% of programs that's estimated to still be using HESI or ATI as part of a progression policy, here's your call. But before you get mad at HESI or ATI, all of these misses in identification are within their stated rate of error. Both vendors will tell you they do not recommend the use of their exam scores for high-stakes progression decisions. So, by design, schools are not using these assessments for their intended purpose. So how did we get here? As it turns out, there are actually a lot of good reasons why predicting NCLEX failure is way more challenging than predicting NCLEX success. First, small samples of NCLEX failures in nursing programs and the margin of confidence for pass-fail determination make the empirical evaluation of at-risk students a challenge. We're really talking about, in most schools of nursing, with the national average of 89 to 90% NCLEX pass rates, we're talking about 10% of any given student body. Very hard to study. But only basing failure risk on known predictors of success results in an intervention for students who may still actually have a high likelihood of passing NCLEX. Furthermore, a predictive model for success is not developed to predict students at risk for failure, leading to an inaccurate categorization of a student whose likelihood of success cannot be accurately predicted by the model as highly likely to fail. Now I want to turn your attention to some related research that was recently published in the May 2025 edition of Nursing Education Perspectives with myself and a few peers that I work with. In this study, we included a total of 3,396 students, including 289 NCLEX failures, who took their initial licensure attempt between 2018 and 2022. Now, the number of failures is important because previous studies included really only a maximum of 30 NCLEX failures in their sample. Now, I know what you're thinking. UTA is actually the largest nonprofit college of nursing in the nation, the largest producer of baccalaureate prepared nurses in the state of Texas. We currently have about 2,000 students enrolled in our upper division pre-licensure nursing program. The overall sample in our research study actually represents an average NCLEX pass rate of 93%. So while almost 300 NCLEX failures sounds wildly high, it's important to note that in the overall sample, it's still only less than 10%, 7% of the students that we evaluate. In our study, we included a total of 22 variables in the initial correlational analysis. The student demographics included race, ethnicity, age, sex, second-degree student, veteran, students who took longer than expected to complete the program, and students who waited more than 45 days after graduation for their initial licensure attempt. Admission variables included in the correlational analysis were science GPA, T-scores, and overall GPA. Other variables included accelerated or traditional program, course grades, as well as predictor and specialty exam scores throughout the program. Now, a substantial amount of the available research on these predictors is both correlational and contradictory. Much of the research related to admission standards in nursing programs occurs before 2012, likely due to a nationwide surge in highly qualified applicants that continues today. So what admission decisions are you using in your own program? Why does it really matter for us to get better at admission criteria? Those are important questions as we realize why this matters to us as educators. The final model included the following variables: online students, delayed graduation, delayed testing, men, graduation GPA, and ATI probability of passing at the end of the program. The final logistic regression model accurately predicted 85% of NCLEX failures, compared to only 30 to 50% accuracy in previous research studies. Students who waited longer than 45 days after graduation to take their NCLEX were 1.5 times more likely to fail than those whose initial licensure attempt occurred within 45 days of graduating. Much of the education literature related to exam performance factors highlights these student-controlled factors such as state and trait anxiety, or how anxious a student is at baseline and how anxious the exam is making them, the quality and amount of their preparation prior to exam day, and their recall memory and cognitive ability. Now, students who delay testing are at increased risk of knowledge depletion, state anxiety, and increased cognitive load, all of which could very easily impact their performance on exam day. So as you can see, some of the most important predictors are outside of the program's control. So we can encourage, and we should be encouraging students to test early and trying to get them to stay in the program and finish the program on time. We can't always control these decisions students make. Nurse educators learn that very quickly, right? Now, another important finding of this research is that males are 35% more likely to fail NCLEX than females. This is a really important finding of this research. It also brings about some really important dialogue we need to be having in nursing education about how well our programming supports non-traditional students. In that regard, let's stop and look at what this research doesn't say. The academic variables of science GPA, ATITs, and pharmacology course failure were not significantly correlated with NCLEX outcome. The demographic variables of age, veteran status, race, ethnicity, and previous healthcare work experience were also not significantly correlated with NCLEX outcome. Now, not surprisingly, students who had a higher GPA at graduation and those with a higher ATI probability of passing score at graduation had a lower likelihood of failure. But, big important but, students with lower GPAs and lower ATI probability of passing did not have an increased risk of failure. These predictor exams still only predict what we already know about the very strong students that we have, and these exams are really lousy indicators of a student's actual risk. Men and students from diverse backgrounds are a crucial asset to our workforce as nurses. Schools should strive to ensure that they're admitted and can be successful. Non-traditional nursing students have unique academic challenges, often due to a lack of faculty support, feelings of isolation, less access to college preparation programming, and deeply rooted societal mechanisms of systemic oppression that pervade American public education for years in this country. Conversations about at-risk student groups should remain focused on how our learning environments can better support the needs of diverse learners, rather than how admission criteria can aid in the sorting and selection of better students. Nurse educators must continue to refine admission criteria to provide more holistic measures of student preparation for nursing and ensure students who can be successful are given the opportunity to do so. Now, in this study, certain groups of students received additional considerations in the admission scoring system. Second-degree students, students employed by a partnering healthcare system, and veterans, to name a few. These students, which are not as academically qualified as their peers, did not demonstrate an increased risk for NCLEX failure. So years and years of educational research has actually reinforced this paradox. Our common academic measures like GPA, SAT scores are really stronger predictors of a student's socioeconomic status, or more specifically, their mother's highest level of education, than a student's actual academic preparation and readiness. Now, higher education touts itself as the great equalizer, but it won't be that until we stop fighting over the most highly qualified students and feel more comfortable taking informed risks on otherwise marginalized applicants that we need in the profession. Now, most of us joke that the best nursing students don't always go on to be the best nurses. But don't we want better for our patients? High-stakes exams are not the way forward for nursing education to ensure our workforce looks like the patients it serves. So this really begs the fundamental question. Are first-time NCLEX pass rates really a measure of our hard work as nurse educators, or do our stringent and non-empirically sound admission and progression policies really only exist to feed pervasive and long-standing disparities in educational access and attainment in this country? Now that we've discussed the legal and ethical guidance we receive as nurse educators for ensuring our assessments are fair and valid measures of students' knowledge, as well as some of the pitfalls of our current practices as educators, let's review some best practices for you to consider as you move forward in your own teaching role. Faculty should receive formal training on exam item development and analysis and should participate in standardized program policy development related to testing and assessment. Testing processes should be clearly outlined in student and faculty-facing policies in the syllabus and should include the following information: procedures for managing absences, late arrivals, unauthorized materials in the exam environment, and technical issues during exams, exam scheduling and accommodation processes, length of exams, including the time per question and the implication of running out of time on the exam, post-exam scoring procedures and the statistical analysis process, or the item analysis, exam analysis process, exam integrity strategies and cheating mitigation technologies and processes, and how standardized third-party exam as well as faculty-created exam scores are used. Programs should obtain a signed acknowledgement from every student regarding test administration policies and how scores are interpreted and used for decision-making throughout the student's program. And finally, testing and assessment should be strongly integrated into faculty governance and comprehensive program evaluation plans. Faculty should report their item statistics and exam analysis to a central location as part of ongoing QI methods. In conclusion, we as nurse educators have an important ethical and legal responsibility to ensure the ways we assess our learners' knowledge are both fair and valid. We can and absolutely should do better to ensure we actively mitigate pervasive inequities due to our use and interpretation of our exam results. It's my sincere hope you will leverage this opportunity to look beyond our collective misuse of primarily summative assessments to unfairly rank, sort, and label our students, and to ensure we're utilizing student outcomes measures to improve the quality of our teaching, as well as provide individualized support to students who need it most.